Healthcare systems are trying to win back their patients' confidence, something that hasn't been made any easier by the second wave of the coronavirus and recent spikes in hospitalizations. What these systems have been learning, though, is that the outpatient experience has been long overdue for a serious overhaul. Joining us today is Derek Veilleux, Principal and Director of the Healthcare and Wellness Practice of SMRT Architects and Engineers, which has been guiding healthcare organizations towards some semblance of normal with their patients and staff. Derek, welcome to the Weekly.
Thank you very much for having me.
Oh, my pleasure. Derek, let's start off. You've noted in writing that both patients and staff need to be made safer about coming back to medical office buildings. Let's talk about some of the steps that your firm proposes, starting with planning, which you believe should begin with empathy and listening. Let's start at that point.
Sure. This has obviously been an incredibly stressful time for patients and staff alike. And so rather than having a knee-jerk reaction, jumping right in and basically prescribing what our clients should do to make their facilities pandemic ready, we like to begin with really listening sessions. We find that really brings everyone along on the journey and helps reduce some of the anxiety and helps people feel part of the solution. And I would say that it goes a long way to surfacing not only what's been broken or what's wrong with the system, but also what have been some of the successes in the organization that they've learned over the last number of months that we want to carry forward.
Mm-hmm. Your second point is about adapting the arrival sequence. And that's very interesting. I'm hearing a lot more talk about curbside entrance and so forth. Tell me a little bit about your suggestions.
Sure. Well, obviously, the first line of defense is the screening that might happen before the patient even arrives at the medical office building. But if we start to think about the physical nature of the building and the fact that many organizations right now are trying to figure out a way to shift from these temporary tents and screening pavilions that they have set up in their parking lots to sort of a more permanent structure, that's when the gears start turning, is how does that actually manifest itself in the projects moving forward. And what we're hearing is that patients have really enjoyed the offering of curbside services, and those have extended not just to testing for COVID, but also to diabetes management, for example, blood work, other screening services that can happen in that environment. And when you think about the fact that there's a lot of elderly, but also families with kids who have a difficult time navigating medical office buildings, those services are very welcome. And I do see those moving forward. I think beyond that, when we start to think about how we make changes to both existing and new facilities, I do think that bolting on drive-through canopies and the like onto buildings moving forward is probably going to be something that we see to continue to support those services. Mm-hmm. But the challenge is sort of what scenario are you in as an organization? Are you renovating an existing building, or are you able to design something from the ground up and design for optimal flows and patient care protocols and the like? And I think the challenge is that traditionally medical office buildings have had, and rightfully so, to support clean workflows, a single point of entry and exit in and out of their buildings. And as you can imagine, that it has inherent challenges relative to COVID. So, we're looking at not only screening pavilions on the exterior of the building, but let's say you have an existing medical office building that is a single story and not a multi-tenant, and you have quite a bit of flexibility. We're looking at creating in and out flows within that building. We had the opportunity actually to redesign on the fly one medical office building that had just started construction when the pandemic hit. And what we did there is we created a drive-through canopy that bolts onto a community room that was near the front door. And that way we can have testing near the front door. If a patient tests positive, we have the ability to get them directly inside into a confined zone, sort of a negative air zone, so that they're not going in the rest of the building with non-positive patients. And it really gives the client some flexibility, especially with so many unknowns right now in terms of how this is going to play out in the future. Will there be an even, bigger pandemic down the road that they need to plan for? And with those questions, I think we're really designing a lot around flexibility, and that's one way that we're providing it.
Mhm. I had a doctor's visit a couple of days ago where I had to actually wait in line to check in just so they could control the flow of a waiting room, which can be a little scary for people right now. Just hanging around and seeing other people relatively close to you. Talk a little bit about rethinking the waiting room as one of your steps for safety measures.
Sure. I mean, unfortunately, the waiting room has always been despised. I think we universally despise the waiting room, and it's not just patients, but I think organizations as well. And I think that COVID has only amplified that distaste for waiting. And so I think what we're going to be seeing moving forward is we're not going to move away entirely from waiting, but I think we're going to see more cases where organizations have patients either wait in their car and they're called in sort of just in time. And I think in those cases, it's probably an existing facility that just doesn't want to have patients lingering in a waiting room. Or those that have the capacity, having patients actually wait in the exam room. And I think there's a whole series of changes that can happen with the plan to support that. It will take a lot of effort from our clients to really think about their scheduling. Some organizations have block scheduling for providers, and it's not the most efficient way to schedule an exam room or to basically hold an exam room for a provider. But I think if we move to unassigned exam rooms universally, I think that's going to give them some flexibility to do that. And I also think that there's some merit in revisiting the self-rooming model as a way to not only downsize waiting, but also to add additional safety to these facilities. And in that model, a patient would arrive and they would check in via kiosk or a person, or perhaps they receive it on their phone and say, please go to exam room 10. Mm-hmm. And they self-navigate there via public corridors, and they're not passing other staff members in that model. And then staff sort of work on the other side of the exam room in a more segregated, compartmentalized, collaborative zone where they don't have to have the variable patients walking by. And then they can enter into the exam room from the other door. I see. So the only way that they meet is really when they're receiving that care in the exam room. And I think that would allow us to shift some of that square footage from the waiting room to allow for additional circulation for this to happen. And I also think it would go a long way to reducing the anxiety for staff. I mean, we can't underestimate the fact that staff has been incredibly hit. Care providers have been hit really hard by this, with, I think, on average, 1 in 7 of COVID cases being healthcare providers.
Yeah.
It's been really challenging for them.
My guess is that some of this will be mitigated by telehealth. Would you agree with that?
I would say that to some extent. I think that the general consensus is that telehealth is probably going to supplement traditional care versus take the place of in-person visits. But with that said, we are looking at new ways of incorporating telehealth, especially in rural areas where patients might not have the technology that they need to have a proper telehealth visit. And perhaps they're seeing a specialist that is in a major metropolitan area and they just can't get there because of COVID or because of other challenges. So we're actually designing now telehealth facilities in buildings that patients can come to, and then they can have their primary care provider there in the visit with them, and they can have a visit with a specialist that's hundreds of miles away.
Mm-hmm. Your last point is probably the point that most healthcare systems have been focusing on, is the engineering of systems to prevent infection. And what are some of the recommendations that you're making along those lines?
Well, certainly this is not something that most patients and staff have thought about until now. And it's a bit of a fear of the unknown and unseen that I think is playing into this. But certainly there's a lot that we can do to create a safer environment. And part of that is going to be visually communicating this safety to patients and staff. So if we're creating negative air zones, adding visual indicators that show this space is safe because it has negative air, this air is being exhausted. I think we're looking at adopting technologies that we've used in other environments, such as operating rooms. In operating rooms, you typically have a low air return so that you're not, recirculating the bad air up through the space. And I think that that's something that we're going to want to explore introducing moving forward. And right now we're using, because we have engineers in-house with the architects, we're able to really take a look at computational fluid dynamics. And I know that sounds crazy for a medical office space, but it's the technology that we're using very much for the clean room spaces we design. And now we're applying it to the medical office environment to understand how air moves through the space, how maybe some dead air zones are created, and how to mitigate that with moving the air around the space differently.
My last point that I'd like to discuss with you is the notion of future-proofing MOBs and whether or not that's practical. Is it doable? What do you think are some of the things that that healthcare systems should be focusing on when they're looking towards the future?
Well, I think right now, again, as I said earlier, it's important not to have a knee-jerk reaction to what's going on and to only plan for COVID. I think what has happened over the last number of months is that it's opened our eyes to a number of other possibilities that we may have had in our blind spot for a period of time. I think moving forward, that one of the approaches that we take is really designing around flexibility. And understanding what flexibility means for one client versus another, it can be very different. It can mean having the ability to flip a switch on the exam room and turn it from a positive air environment to a negative air exhausted environment. When you, for example, have a meningitis patient or someone who's suspected of having it show up without much notice, and being able to pivot on the fly. But flexibility can also range from designing a building platforms that can be easily renovated down the road, and figuring out how much we want to invest in what type of flexibility is an important part of our day one thinking. And I think the piece that ties into that is scenario planning, really taking the time at the beginning to understand what are all of the different scenarios that we can envision moving forward, and designing the building to be as flexible as possible to allow the users to use it depending on whatever scenario arises at any time.
Derek, thank you for sharing your thoughts on this. This is an issue that is obviously not going to go away anytime soon. So we'll be keeping an eye on it, as your firm will as well. Thanks for your time.
Thank you very much.
This is John Caulfield from Building Design and Construction.